get started. And this session, I titled it Home Care for Activists. So I want people to understand what home care means, and then we'll get into what some of the issues are and how people can advocate for it. I'm going to start with the history a little bit, because I think, if you understand the background, you often have a pretty good idea of what's going on. I'm going to start with the very basics. In 1965, Medicare and Medicaid passed, and Medicaid is what pays for over half of the long-term care in this country now. And before that, people had to private pay it at nursing homes. And now, as I said, Medicaid covers a good chunk of that, and it also covers home care. It also grew the nursing home industry enormously because there were all these new dollars and so a lot of people invested in nursing homes. So there was a huge increase in the number of nursing homes in this country. Now, in the 70s, there was the beginnings of the disability rights movement. And in 1980, there started to be a new paradigm. I'll use Illinois as an example most of the time. Some states may have been ahead of Illinois, some behind. But in 1980, people with disabilities started demanding access to home care services. And a big chunk of the people that were demanding that were young people who were headed to college, who had somewhat grown up with the Individuals with Disabilities Education Act, and a lot of the folks that were very active at that time in the movement were people who had not been disabled but had a spinal cord injury or a traumatic brain injury, and they demanded this assistance because, well, there's the dichotomy of people born with disabilities and those who develop them, and they have slightly different outlooks on disability. The people who became spinal cord injury knew what it was like not to be stigmatized and discriminated against in the same sense. And in some ways that was an asset. People who were born with their disabilities had more of a sense of a disability community, I think. But the assumptions were starting to change. They wanted to have as close to a regular life as possible, given their need for care. Now, home care obviously was very small at first, and that meant that the budgets were small. The wages were awful. When I started at Access Living in 1990, I think the wages were $4.25 an hour, and they had been even lower than that, lower than minimum wage by considerably even. So how they got away with that, I don't know. The demand of the people with disabilities created these programs, and it came with a high demand from them for control over their services. And so the earliest programs, they had a lot of input into the design, and that input was quite often accepted by the states because the people that are working with the state knew these activists. And so they were working closely together to design these programs. And, as the disability rights movement developed in 1990, many of you know the Americans with Disabilities Act was passed. And part of the Americans with Disabilities Act said that people with disabilities had a right to live in the community, full lives in the community. And that was tested many times in the courts. And by 1999, it went to the Supreme Court. And in the Olmstead decision, they backed up this idea that people who have care needs have the right to live in the most integrated setting appropriate and available to them. So, legally things were progressing. And obviously this meant the programs were starting to grow too. The programs were, people, as they heard about the ability to live in the community, more people wanted to do it. And so the people who were coming into the program were more diverse, more racially diverse in particular, because a lot of the earlier activists were, I would say, college educated and white. And if you look at Illinois now, the biggest density of areas of people getting home care service are the south side of Chicago and the south suburbs. And we know that that's because of health disparities and violence, and the needs for of people needing home care service is higher in often in poorer communities. The other thing is that I've been talking about home care for people with physical disabilities. And in the meantime, there have been programs being developed for people with intellectual disabilities. That was partly a movement of parents, but there were also activist groups. Mike can tell you quite a bit about activist groups for people with developmental disabilities, right, Mike? He's been involved from early on in some of those. The idea of independence is spread, and so there were also age differences as well as class. The poor people were still more likely to end up in nursing homes and institutions, and the difference in the services, in Illinois, you have the seniors program, the community care program, and you have the physical disability program, the home services program. Well, they're very developed on very unequal tracks. And I've always said that there needs to be a lot more equity in home care between the different age groups. Seniors get a maximum of 20 hours a week, only Monday through Friday. And while that can keep people from going into an institution, it doesn't provide the independence and freedom that people with disabilities have fought for. People with disabilities, can get anywhere from a few hours a week up to maybe 70 or more. And people with disabilities can get services if they need them 7 days a week and in multiple times a day, including crucial times for home care services are getting up in the morning and going to bed at night. And obviously, while there's different levels of people that qualify for home care services, the higher end users are often people that require help with transfers, with going to the bathroom, with bathing. And so their needs require staffing during various shifts during the day. And those needs are not always met as well as they should be, obviously. Now, one thing that started to happen a little bit was in the era of, since Reagan, of somewhat austerity, the high cost of nursing homes started to cause some promotion of the idea of home care services, because the program home care services have almost always proven to be significantly cheaper than institutional care. And the community care program grew with the idea of delaying people's entries into nursing home, not necessarily preventing them from going into nursing homes. We also in Illinois have had institutes for mental disease, they were called, for many years. These were nursing homes that were a majority of people with psychiatric disabilities. And a lot of those nursing homes were only funded by the state. And while all nursing homes are pretty crappy, a lot of these IMDs were pretty awful places. And the mental health community and some consumers there have fought quite hard for more community services, and they've grown significantly here in Illinois in that regard. I just still want to mention that, with seniors, there's not much personal care. A lot of it's homemaking, cooking, cleaning, and not the real what I would call the heavier work of transferring and helping people and get to the bathroom and stuff. Another significant factor to remind people of is, as we know, Medicaid is you have to live in poverty pretty much to qualify for Medicaid. Now, the home service program has some differences from Medicaid for just health care. You can be earning, working and earning a little bit of money, but it doesn't allow for assets. And Susan's got a phone call here. So anyway, the thing that that has is that, like healthcare in general in the U.S., we don't have universal healthcare. We have what I have sometimes called healthcare apartheid. You have the healthcare that you can afford or that the government's willing to pay for you. Well, long-term care is also that way. If you're rich, you can afford to hire people to take care of you. If you're middle class, you're going to wipe out your savings if you need long-term care quite often and end up on Medicaid. And you know, like I said, you can't really have any assets. And if you're in a nursing home, they keep all but $30 of your earnings per month. So that's guaranteed that you're going to live in poverty in the nursing home. And in the community, I mean, really, while they say you can own a house and a car, the asset limit is so low that if your furnace went out, you know, you're going to be in big trouble if you own a home, for example. So that's a huge class issue. Another significant factor in home services is the disability community has always had a big consumer base to advocate for those services. But for seniors and some of these other communities, it was the professionals and the people making money off of the services that were the main advocates. So the programs had very different shapes depending on who was advocating for them. And a lot of times in the senior community, they don't see consumer directed care as very important because there's often the assumption that these seniors want to be taken care of, that they don't want to decide when their caregiver comes or who the caregiver is and such. The other thing that's happened a lot is the money has grown in home care. There have been a lot of people looking to make money off of it. So investors have looked to privatize what were public dollars in the home care system. And they see the home and community budgets as a way to put a lot of money in their pockets. And you know, in Illinois recently, I just have a few dollar figures here. In the US, in 2018, we spent $92 billion on home and community-based services, and that served about 2.5 million individuals. And in Illinois, in 2017, the state and the Fed figures together were $18.5 billion. And in Illinois nursing homes got $4 billion of state money. And if you look at the figures, the community services and the institutional services, we're spending about the same amount on them. Now, when I started at Access Living in 1990, about 90% of the dollars were going to the institutional settings. So you can tell that we've made some progress on shifting that. But one of the things has just been that they've grown the budget. So the number of people getting the services has grown, but the number of people in institutions has not shrank a whole lot. And that's always been one of our goals, is to free people from the institutions. And I just had Mike down. Mike is here, and he spent a number of years in nursing homes. And Mike, do you want to say something about what it's like to live in a nursing home briefly?
It's very impossible to have a life in a nursing home because you're at the mercy of staff that works in a nursing home. can't can't go out when you wanna. Can't basically. I couldn't get up when I wanted to get up because I was at the of the CNAs. A lot of days I didn't get up. I remember one day when Susie came and it was 3 o'clock in the afternoon and I was still in bed.
Yeah.
And she came in my room and said, what the, what the hell are you still doing in bed at 3 o'clock?
Yeah.
But she went to the nurse's station and less than 20 minutes, I was up. But it takes that kind of
Advocates.
advocacy and circle of friends that you have to have in order to be able to survive. And I spent 35 years of my life in 8 different nursing homes. 35 years is a long time to be involved in nursing homes. But within that 35 years, I had to develop a very thick skin and not give up. I knew when I transitioned out of the last nursing home in 2014, if I didn't get out, I wouldn't be here today because I had lost hope. I didn't see any hope if I didn't get out because it's impossible because you get no support from administrators or social work when it comes to any support. You have no way of communicating unless you're able to figure out how you're going to make phone calls. But what I was able to do is leave out of a nursing home without having permission.
I'm gonna move back to the home care. One of the things that as the budgets grew, you started seeing people trying to tap into the public dollars. And one of the things is that agencies started trying to recruit people to be the to provide the caregivers, because in the home services program, about 90% of the people in the early days hired their own caregivers, and about 10% went to agencies. Well, the agencies were always trying to find ways to get more of those dollars. Tech companies also became real involved in trying to tap into those state and federal dollars. One thing was emergency response systems. Those companies started trying to promote those, which aren't a bad deal, but if you qualified for the emergency response, they would often cut the number of home service hours you got. So they were pitting the one thing against the other. And more recently, the EVV system, it's about tracking the hours of the PAs, and these tech companies lobbied in Washington, D.C. when the Affordable Care Act was coming out, and they got it written in that all the states had to adopt some sort of electronic visit verification system. And you know, what it has become is kind of a way of spying on people and checking on people. And the thing is that they sell it as a fraud prevention device, but the reality has always been that the agencies commit 10 times more fraud than the individuals do. There's studies that show that. And so these corporations are coming in. The one I think in Illinois is called Sandtrax. And when it first came in, the computers didn't work right, didn't register when you did call in. It was very confusing, and people still have trouble with it. And in California, they just were fighting it and lost in many cases. And just across the country, it's been an issue where long-term care, home care consumers have felt like they're being spied on in their own homes. What's that, Susan? Okay, Susan.
And your hand is raised.
Yeah, Ann, go ahead. Ann, are you there? I see a hand raised.
No.
No. Okay. The
Does anyone have any questions? It's a lot of info all at once.
yeah, this is going to be a little dense. This whole fraud thing, a lot of it compares to like how Reagan attacked welfare by talking about all the frauds and the cheats. Well, these tech companies did the same thing with home care consumers in order to get their mitts on a lot of these dollars. The other thing that's really been hard on long-term care has been Medicaid managed care. It's created a more bureaucratic system. It's put another layer between the state's home services program coordinator and the consumer. And while the state is still the one who qualifies people for the service, in theory, the managed care companies now are supposed to determine the work plan for the PAs that work for you. And the reality is that these managed care companies still to this day, and we're well into their time, have no clue as to how home care should work. They have no expertise in it, and they they just become barriers to really meeting the needs of the consumers in many cases. It's a less responsive system because you have multiple counselors that can be dealing with you, and it takes money out of the system that should be going to care. It's a lot like our healthcare system in general. The money is not going to the care, it's going to managed care companies, which are insurance companies. As I've mentioned before, I want to really emphasize this. The voice of the disabled are the ones who created the system, right? And they have had a profound effect in the early days. But there's been a shift, and I would say in the last 10 years in particular, the voices of the people getting money from the home service program has also started to be a force in Springfield in the legislature, taking away power from the consumers. And while the consumers are still active in Illinois, they do not have as much of a say in it. We've seen this through both Democratic and Republican administrations. I'd also just mention that, in the early days, the unions and the consumers fought a lot to raise the wages of home care workers. But as the unions have gotten stronger, there have been some, what would I say, the solidarity between the two groups is not as strong as it was at the beginning. And sometimes the union's interests and the consumers have gone in separate directions to some extent. And so we're seeing more voices of professionals without disabilities Again, going back to the political side, in Quinn's administration, we had Medicaid cuts. They brought in the managed care organizations, and this was a way to privatize a lot of the long-term care dollars. Ronner was just out to destroy human services in general, and that had its negative effects on long-term care. They were cutting hours and making it, when the feds changed the law, they made it impossible for PAs to get overtime. And that meant that it made it harder to find PAs. This is the neoliberal agenda has affected home care significantly. The idea of shrinking the state means less tax money for long-term care. The state has not found a way to tax the rich. We still have the flat tax. They've been privatizing healthcare services. They've been attacking workers. And, the other things at the federal level is, the poverty of people with disabilities is really SSI, I think, has not kept up with inflation. So people with disabilities are really poorer than ever. Yeah, I would compare it a little bit. You see the help wanted in restaurants and how they can't find school bus drivers. And the PA field is definitely affected, even though the wages have been going up a little bit. I mean, if you're not getting enough hours, you're screwed. And the cost of living and the cost of rents are so high that, even $15 an hour, which we've been fighting for a long time, doesn't cover the cost of living for a lot of folks.
And now there's a cap on hours. Quickly.
Because they don't want to pay overtime.
Yeah.
And it's.
Yeah, and vacation and other benefits are still very meager. So I just wanted to mention some other problems. It takes months, if not years, to start services. There's waiting lists in a lot of places. So if you're in the hospital and the easiest discharge is directly to a nursing home because they'll take you immediately. But if you want to get home care services set up and you're sent home, you may not have any care for a very long time. We've seen that as a problem. State systems differ, and you can't move from one state to another. You lose your services and then you have to reapply. And I used to see cases where people changing states to go to college would get picked up fairly quickly. But when Susan moved to Colorado, it took her 6 months to get on a new state's program. And that's just not acceptable.
Now it's even longer because I've been there 2 years.
The evaluations and service plans are not always honest. There's a lot of, particularly in the Ronner years, there was a lot of pressure on counselors to cut people's services and hours. And the managed care organizations don't seem to have a real good understanding about how long it takes to care for some people. And so there's a lot of times people aren't getting really the number of hours they need in the community. Home and community services, often people don't get any community hours, even though it's called home and community. And people don't want to be stuck in their homes and they want to have a life in the community. And for some people that requires transportation assistance or assistance going to the bathroom while out in the community. And they've made it much harder for people to get that level of services in the community. That's a pretty universal thing. Any questions? If not, I still have a little bit more to go through. I think one of the biggest points I want to make is that consumer control has really been undermined, and the cloud of the nursing homes never ends. We saw in the pandemic how the nursing homes got bailed out, lots of extra money thrown their way. Home care, people couldn't get the masks and the protective gear they wanted. So there's a different level of, what would I say, access to power within the two programs still. And as the professionals take it over, they don't fight for independence and freedom. They fight for dollars. So that becomes a huge problem for the consumer as other people are fighting for them or in the name of them, but not really getting what they really need. Now, to get to advocacy just a little bit, I think that we have to put the consumer voice first, but people with disabilities on home care, in Illinois, as we said, there's 46,000 people in Illinois getting physical disability services, 23,000 getting developmental disability services. In the seniors, there's 85,000, and in the children and AIDS programs, there's 2,500. The cost of the programs, the people with the intellectual disabilities are actually the most expensive programs. And we're still spending a lot of money on institutions for people with intellectual disabilities. Illinois still has, I think, 6 or 7 state institutions operating, which is more than any other state except maybe Texas. I just wanted to talk about 2 home and community-based services at its best, allows active life in the community, freedom of movement, flexible hours and schedules. Susan, for example, doesn't want to be going to bed until after 10 o'clock at night. So she needs PAs that might be willing to work until 11 at night. That can make it hard to find people. There maybe should be a premium payment for those hours or something. People want choice of their clothes, their food, their entertainment, none of which is possible in an institutional setting. And people with disabilities want the ability to work, and you certainly can't do that in an institutional setting. Legislators have biases. The institutional bias is strong. We see it, the medical model that doctors grow up with, that has and social workers are often in the medical model, as well as others. And those voices get heard by legislators too. So, and they're often very paternalistic. They want to protect the person with the disability. They don't want to free them or liberate them. We also have overprotective parents, which push over regulations and controls on people with disabilities that don't want them and don't need them. They promote this idea that we shouldn't allow people with disabilities to make bad choices. Well, we all make bad choices. They try to not allow people with disabilities to take risks. Well, taking risks is how people advance oftentimes in the world. The other thing I just want to mention is obviously legislators don't get money from the poor, and they don't get much money in campaigns from people with disabilities. So, but the nursing homes and the other providers are stuffing lots of money their way. There's another problem is that you have to be a US citizen to qualify for these programs. So there's a whole bunch of people that are left out where they're depending on family care, which may be inadequate and certainly is uncompensated. I've always talked about home care and the disability community is all we have is people power. We never have the money that our opponents have. And one of the things that Access Living, and I know Progress has done this some too, is, we would visit the legislators, taking like 35, 40 people at a time on the train, and talk to all the legislators of the people that are going to Springfield. We do visits to their offices and stuff. Without that, you get run over entirely by the people with money. And, if we don't step it up, things are going in the wrong direction. And I think that they'll continue to go in that way unless we step up our advocacy. What people without disabilities, I think, need to understand just how liberating and freeing home care services is for people with disabilities. Without that understanding, the right policies are nearly impossible to come by. I'm going to leave it there. As Susan said, it'd be nice to discuss things. Maybe people have some experiences advocating they want to talk about. In Illinois, we've had some champions for home and community services, but as the turnovers happen in the legislature, you're always having to find new champions. I know I went through a lot. I hope that was helpful though. And like I said, if you do have questions, I see Kira has her hand up. Do you want to?
Yeah, sure. Hi, guys. This is Kira. Just to add a bit in regards to what Tom was saying about funding. Well, during the pandemic, Illinois did apply for what they call Appendix K waiver. It's Medicaid waiver. It's specifically for emergency preparedness and response, specifically to COVID-19 at this time. I'll post the fact sheet I found, but what it looks like is that our state did get funding for emergency response. A big chunk of it went to the Division of Developmental Disabilities. So it didn't go towards home and community-based services for folks who have physical disabilities. So that's a concern, and we've seen that play out in a number of ways, such as even personal protective equipment. To my knowledge, it's being reported to me more and more that people were only able to get personal protective equipment once this pandemic, provided by the local offices. So even though Illinois' Emergency Management Agency seems to have a plethora of those supplies at this time. So I'll post that fact sheet if that's helpful for people.
Yeah. I just want, Kathy is up next. I just want to reiterate that it's the voice of the consumer that makes the difference here. And when you talk to legislators, you need to tell them that they need to listen to the consumers, that they know what their needs are much more than any professional can ever know, really. Kathy, you have your hand up.
I do. Now I'll put it down
Okay.
because I forget. I want to talk about the voice of the consumer with consumers who have mental illness, who are locked away, who don't have a voice, and even if they spoke up and made a whole lot of sense, they're crazy and nobody's going to listen to them. The stigma is unbelievable.
Yeah.
And getting, I've tried working through the drop-in center. I asked people, some people who are in nursing homes are there, they're in Smurfs or something. They come to the drop-in center because they don't get anything in the nursing home for sure. And I try and keep track of, who's trying to get out, how they're being treated. And I don't know what to do about it. I really don't know what to do about it, because that's a group of people who really do have a voice, and we found some. We absolutely have found some. But I don't see, we've actually had to go get consent decrees, and of course now the pandemic, well, forget the consent decrees. They weren't even doing it before the pandemic, especially for mentally ill folks who are trapped in nursing homes. We don't have public mental health services per se. They have very, very little, very, very little. And we're getting no supports at all. And I don't know what we're going to do about that. But I'm hopping, man. I don't want to be in a nursing home.
Yeah, and I'm glad you brought up the lawsuits. That's been one way that we've actually been able to implement some of the Olmstead decision that the Supreme Court said that people have a right to live in the community. But it's, people have had to go to court to force the state to do what they're supposed to do anyway. This is again where biases come into play. Right. I helped design some of the transition programs here in Illinois. And from my experience, the desire to live in the community was always 10 times more significant than the assessment of some professional that said, oh, you're too disabled to live in the community. That's bullshit. And yet that attitude is out there among a lot of professionals.
Right. And it's out there more now, I think, than ever.
Ever. Okay, any other questions, any comments? We're trying to keep this to an hour, but happy to have any, I appreciated what Kathy said about the stigma, you know. I mean, people with disabilities have to fight to be heard because their views are devalued often.
And also, the disability, that,
Yeah, although not too many people with invisible disabilities get home.
I think one of the things that we really have to work on when it comes to consumers in nursing homes is finding a way to get them technology.
Yeah, and I'm just going to mention, Fran brought it up in the chat. The Alliance has had a program to organize people in nursing homes. And I think that that's been an incredible effort. Christia has been the one managing a lot of that. And, you know, again, that's the consumer voice that's needed to move things forward. And we need to build stronger organizations. I would also just mention, you know, I worked 28 and a half years at Access Living, but yet, and Susan has worked at independent living centers, and Mike too. Not all too often, they're becoming more social service providers and not advocates. And I see a weakening of the voice of people with disabilities as they become more into providing services and less into speaking out. All right, I
And
think,
not necessarily getting the services they want or need.
no, that's it. Somebody else is deciding. That whole thing about consumer voice. Somebody
yeah.
else is deciding what they need. That's not right.
a lot
Yeah.
of it is good money.
What I was gonna say is, I was looking at what Kira was sharing on here, and it seems that PAs are gonna be getting a raise pretty soon, hopefully.
Yeah.
But it's not enough. If you look at the CNAs, the people who work inside nursing homes, I'm like, come on, they really deserve a raise?
Well, these are the wages for CNAs in the home service program, Chewy. And some people have some CNA hours and some PA hours. But the reality is that most of the hours are paid at the PA rate. And the CNAs in nursing homes are often starting at much lower wages than what this program pays, I think.
Yeah. I'm just saying, you know, I mean, the way our people are treated in the nursing homes, and then they're requesting a raise, it's like, I don't want to, I mean, as an advocate, you know, I see how they treat people in nursing homes, and I'm like, wait a minute, why should I advocate for you when you can't even treat a person with like a human being? You bring your problems to work from home, and you carry them to work and take it out on people who live here, who don't deserve to even live here. They deserve to live in the community, but they live here because their families either stuck them in there or because of health conditions.
Yeah.
And, you know, and to be treated with disrespect, that's not good at all.
Fran, you have your hand up, and then we'll go to Kathy after that.
Yeah, so I did want to partly follow up on, Tom, you already mentioned that on Thursdays, it's the committee of the IRC that had the resident group that's been meeting every Thursday since right after the Sheridan Road March from last August. And it's really small, but it's been really powerful that people locked inside institutions are able to actually communicate across buildings. And some of it is just peer and emotional support. It's like, oh, you're not alone. So you're standing up for things in your facility, in your nursing home, and you'll get some support. We have had some of the ombudsmen participate, not all the time, but now and then. So sometimes it's an opportunity to raise the issue directly to an ombudsman. But ultimately, we are, like so much else, building the organizing and the advocacy. And we want to get more folks who are in more facilities, more deeply involved, so that they can have a stronger voice and make some of the demands on what happens. The other piece is that, it's we've been, obviously it's, the consumer organizing and consumer voice has been so central to having this program exist at all. And I think sometimes people forget that there's decades of work that some amazing people have done to lead this charge. And we want to make sure that that consumer experience continues to be a lead in all the work we're doing in the advocacy work. Two pieces related to that, or really one piece, is that we've talked about, and we would be really interested in hearing if anybody's willing to work on this particular project. We've talked about doing an intentional, sustained, like a 2 or 3 month outreach effort. And NA4J's Human Services Committee has been talking about this a little bit, and other folks as well connected to the Alliance. You really do this outreach to DOORS workers, partly to get their perspective and their experience of what's happening, but also to educate them on where the consumer end is really coming from. And ultimately the hope is that by having more peer-to-peer interaction, so much of this stuff with whether it's a DOORS worker or some other employee, there's this power imbalance, and too often the worker, even if they're well-intentioned, kind of has this idea of, oh, I know what's going on and I'm going to decide. But trying to move that into a peer relationship where folks can actually learn from each other and then band together to demand stronger programs that really work is one of the things that we're hoping to do. So I'd be really interested in if there's folks on this call or in general, if you know of people that might be interested in be willing to be part of that project, would be great.
Yeah, I think there's some ways we can reach out to some people. Just this week on Facebook, I saw a consumer that I knew from Access Living. He was I won't call it begging exactly, but he was in desperate situation, needing a PA, and was using Facebook as a way to try to find PAs. Yeah, Kathy?
Thank you. On that chart of raises, I didn't see anything about homemakers. And I have a homemaker. And I want you to know that if I didn't have a homemaker, I couldn't get my laundry done. I couldn't get my bed changed. I couldn't get my floors cleaned. And what happens when you have a mental illness in your diagnosis, if your way of living degrades, they put you back in a nursing home. People underestimate the importance of the homemakers. Now, I don't need a PA yet. I don't know what's going to happen. Things aren't going well, but I'm still okay with the homemaker.
Yeah.
And are they getting raises? I don't know.
Yeah,
I keep telling my homemaker, I said, I think you got a raise. I think you got a raise.
Yeah, I was talking about the equity between people with disabilities and seniors. 60 is kind of the magic age, and the community care program basically is just homemakers. I talked about how there's very little personal care, but they do help with the laundry, the shopping, and those kind of things. Well, people who are disabled who get the service before they're 60 continue to get the personal care as they get older. But if you have that same need and you're over 60, you're going to get that homemaker service and not the PA service. That's just not allowed in the community care program. So, building bridges between seniors and the disabled. I mean, the people in the community care program, I characterize as older people with disabilities, right? But really, they all should be judged in the same standards and getting the same levels and qualities of care that they need. And seniors are definitely the ones that are being shortchanged in that program as it is now. So in talking to legislators, there's a need to boost the senior programs. And again, it's the whole class and race breakdown thing. You have to be in the senior care program, the asset limits are somewhat higher than the disabled one. But if you have too many assets, you're not going to get help there either. So. All right, I think we're over time. Anybody want to have any concluding remarks? I just hope that the information was somewhat useful and helps us in organizing and onward in building what I like to call, a more caring society. We spend our money on war and tax breaks for the rich and all kinds of crap, but we really need to spend our money on human services. And I would just mention at the federal level, there's the human infrastructure bill. There's actually billions in there for home care. Now, whether it's spent properly is still up for grabs, but having a few more dollars in that area would not be a bad thing. And at the state level, I know there's health and medicine. Some other groups are trying to boost programs for seniors, but again, they're not listening to the consumer voice very much, which aggravates me, even though I'm on their board. So I try to be the voice of we need to listen to the people who are getting the services. All right, thank you all for attending. I hope there was some useful material here for you all.
Thank you for doing this, Tom. You couldn't be anywhere else. So thank you.
Yes,
Yeah,
so
thanks, Tom.
Can I ask you something real quick?
Oh, sure. This is Kira. Real quick, it's just something to put out there is maybe we need to start filing complaints.
Mm.
Maybe there are certain arguments for lawsuits and complaints here. I mean, even the issue around the fact that, just because you're over the age of 60, that means that then you get significantly less amounts of support in the community. That's bogus. That relates to age discrimination.
It is.
And that's something that I've been talking to Quit for Equality about. So I mean, I don't know, maybe we just need to start getting more aggressive and filing complaints against nursing homes, against state agencies more, and working with the Quit for Equality. So I just wanted to put that out there.
Yeah, I think the legal part is important, as Mike would tell you. It's made a difference in his life. But the advocacy in the legislatures has to be equally or as important as well.
Is there a legislation that you'd like us to help push our reps to pass in the state or federal levels, or is there something that we can put together to tell them they need to introduce?
We're kind of between sessions now, and so the bills generally get introduced in January, so I don't have too many particular bills I can point to at this point.
Okay.
I wish I could say more on that. Yeah, Kira has some ideas about bills we want to promote. We've been doing stuff around emergency services IEMA is the Illinois Emergency Management Agency. It's the FEMA of the state. And we want to create an office of access and functional need to meet the needs of seniors and people with disabilities in emergency situations, because they're not very good with that.
Yeah.
And I'll leave it at that for now.
Yeah, this is Kara. We create. It was the last legislative session, Senate Bill 921 was passed actually unanimously between, by the state Senate and House of Representatives. And that created an advisory committee within Illinois' Emergency Management Agency. But our plan all along was to create an Office of Access and Functional Needs, because we deserve not only to be at the table, but be paid for our opinions. And to enforce that accountability and implementing these things, according to the folks who will be part of that advisory committee. So that'll be our next step. So we've accomplished one feat, and hopefully we'll accomplish another one in the spring.
Yeah, so I guess as long as we're talking about legislation, I mean, right now at the city level, there's going to be a huge battle around the budget, right? And there's already an ordinance and called it a budget proposal for all the American Rescue Plan dollars, which is 800 million have come in so far. It's going to be 2 billion coming into the city as a whole to the city, and then another 2 billion to the Board of Ed. At any rate, there's an ordinance, a Chicago Rescue Plan ordinance that came about, a coalition of organizations and some progressive legislators, and within that package, there's a significant amount of money for to reestablish mental health clinics or treatment not trauma. So anyway, some of the stuff that we really need, to be able to for people to be able to continue to survive in our communities. So there's going to be a lot of things happening in the next month around that. Lightfoot, already proposed to increase the police budget by $189 million. If we defunded the police, which get 40% of the corporate budget, I'm sure we could devote more money. Then you win things, and then you have to also then put them into what's really needed. But it's sure helpful to actually have that money. So those are just some of the things that I know about.
Yeah, we're still seeing the bad effects of the mental health clinics that Ram closed. And that really, really does need to be restored.
I just wanted to ask, is there going to be a link to see this recording later on, or to pass it on to other groups?
I'm not used to doing this, but I made the recording. I'll try to send it out to everybody that was on here if possible.
Oh, thank you. I'd like to share it as well.
Okay. All right, thank you, everyone.
Oh, one more thing, Tom, sorry. Kira, I tried to sign that petition, but what would be the subject? Because it says choose a subject that it would go under. What would be the subject that I would have to use?
This is Kira. I think you should refer to Fran. Fran, you posted the link, right?
Yeah, so I think you're looking at the input screen that some of the representatives have. So they are trying to create pigeonholing in the process. So in their drop-down menu, pick one that fits what this is. So you can select among their options and indicate what they want to do, right? So Quigley obviously has got one of those things.
Yeah.
So,
Health would probably work.
health is good, yeah.
Okay, cool. Just wanted to know that so I can continue on with that.
Yeah, thanks, Julie.
Yeah, that's great.
Thanks, everyone.
Yeah,
Thank you, everyone.
we'll see you all soon, hopefully in person at some point.
Yeah,
Yeah.
indeed.
We're
And
here.
thanks, Tom, and everyone to put this together. This was really great.
Thank you all.